Good afternoon, everyone. Thank you for joining us today. We're very excited to have you. Good afternoon. We are here for the MTAC Required Enhanced Training of Introduction to Culturally Responsive Crisis Care for Tribal and Urban Indian People. We have amazing presenters for you today and very excited for today's presentation and opportunity for learning. If you could please take a moment, we're going to put a link in the chat just to get us started with the insightful activity. The link is a website that helps you identify which native land or indigenous land you are on here in California, and all you have to do is enter your zip code. We're going to put that link in the chat. Feel free to let us know which land you're on in the chat. Also, feel free to let us know your name, your agency, and what in your role within your agency in the chat. That way we can welcome you all. And this is the Mobile Crisis Services explanation from the BEN. So we know that mobile crisis services provide rapid response, individual assessment, and community-based stabilization to Medi-Cal beneficiaries who are experiencing a behavioral health crisis. And they are designed to provide relief to someone experiencing a crisis through stabilization and de-escalation. As you all know, this is a new direction for mobile crisis services in California that is really transitioning for mobile crisis response services to be more resolution focused and provide relief to people in the community. As always, mobile crisis services should be person-centered, trauma-informed, equity-driven, grief intervention, so de-escalation and resolution focus, working from the least restrictive lens in terms of intervention, so unnecessary law enforcement and hospitalization, and as always, culturally responsive, linguistically appropriate, and accessible. And welcome again to today's session. Here are our presenters for today. I'm going to hand it over to them so they can do quick introductions of themselves. Take it away, Josh.
Bonjour. Bonjour. So welcome. Hello. Mino Gijagad. Good day. That's my Indian name, Dakota name, and Indijnakash is what they call me. So my Indian name is the Warrior Who Heals, and my English given name is Joshua Severance. I'm an enrolled member of the Little Shell Chippewa, and I'm also a descendant of the Yankton Dakota and the Gros Ventre Union. And I serve as a behavioral health advisor for Kaufman and Associates. And I'm happy to share the space today with you all and with my wonderful colleagues, Holly and Dr. Warrior.
Thanks, Josh. Hi, everybody. I'm Holly Echohawk. I'm the Senior Behavioral Health Advisor for Kaufman and Associates, and I am a member of the Pawnee Nation of Oklahoma. Both sides of my family are Pawnee Nation members for eons back, and I'm really happy to be here today and looking forward to the discussion and looking forward to hearing from you all as we give you those opportunities. So thanks for joining us.
Thank you both, and good afternoon, everyone. My name is Anitra Warrior, and I'm also a behavioral health advisor with Kaufman and Associates, and then my other position is with Morningstar Counseling. I'm from the Ponca tribe of Oklahoma, and my Ponca name is Mingle Dawi, and that means moonhawk. Within our tribe, I'm from the Blood Clan, and so I'm very honored to be in these spaces and to provide support to our relatives in the way that we do, because that aligns with my clan. Within our clan, the Blood Clan, we actually serve as like protectors for our tribes, for our relatives. And so it's a role that I hold very dear to my heart. And so thank you for allowing me to share this space with you today.
This is the land acknowledgement exercise we just did. The link is in the chat. We can place it again as well. So if you click on the link, you can go to the website, which will allow you to plug in your zip code, and it will tell you which native or indigenous land you are on. Land acknowledgements are a respectful way to start very meaningful conversations in support of indigenous communities and to honor their enduring stewardship of these lands, as well as to elevate the presence and voices of Native people, past, present, and future. And so we really wanted to just take moments to acknowledge and recognize and respect. And so thank you. So we're going to go have a quick overview of tribes in California, talk a little bit about the different types of crisis, go over some data on and ethical requirements, really get into the nitty-gritty for culturally responsive care, intersectionality, and mobile crisis services, incorporating other cultural factors that impact mobile crisis services through a trauma-informed approach while working with tribal communities. Also talking about crisis communication, treatment protocols, and then we'll have a quick Q&A.
We have 3 broad learning objectives for today. One is the information we provide is for you, and we want to help increase your knowledge. We know you already have knowledge, but we'd like to help you deepen it with knowledge of cultural norms, approaches to healing, and social structures within diverse tribal and urban Indian communities in California. We will describe core principles that we're going to share with you of culturally responsive mobile crisis care specific to Native people in California. And the third learning objective is increasing proficiency in culturally informed communication. And sorry for a minute, the things are popping up on top of my screen, so I can't quite see the rest of it, but culturally informed communication skills. So onward.
There should be a poll that pops up. We're just curious to see how many federally recognized tribes are in California. So if you want to just go ahead and plug in your answer, we will share the results. Yeah, thank you everybody for
36% of you are absolutely correct. 109 federally recognized tribes in the state of California. So we're going to share some little bit of background information with you all about Native people in California. So California, well, let me back up and just say that I forgot to mention in my introduction that I have lived for 26 years in California. Starting in the 70s through the 80s. And now I live in the Portland, Oregon area, but I have lived in the Bay Area. I went through was there during the AIDS crisis, the George Moscone murders. So lots of that upheaval. So I lived in San Francisco, Oakland, Martinez, out in Contra Costa County, San Diego, Humboldt County, and I worked in Sacramento for quite a while as well. So I'm pretty familiar with California and the Native population, and was part of the urban Indian population for all those decades. And still am as a alumni, I suppose, of the Bay Area. So California is a super exciting place, as you all know. It has the largest tribal population in the United States, followed by Oklahoma, the state of Oklahoma, and the state of Arizona. The Native population in California is also incredibly diverse. A lot of the other states, like the Dakotas, the tribes there are all Plains Indian tribes. So there's a similarity. In California, not that way. California is very diverse. So the tribal population, which is about 750,000 tribal people, includes the 109 federally recognized tribes scattered from south to north, east to west. And some of those tribes have land that crosses over state boundaries. So it's from a jurisdiction perspective, that gets a little more complicated. There are also many other tribes that are not federally recognized. And when we get to the Q&A, if you'd like to have more information about what that difference is, we can deal with that, talk about that later. But there are there's about 75 tribes that are tribal intact, but they do not have federal recognition, and so they're in the process of petitioning to gain that status. There's also over 100 separate reservations and rancherias. And you know, in California, rancheria is the status that is used, very few reservations. And, you know, the largest tribe in California is the Yurok tribe up in Del Norte. Beautiful place. And there are 10 urban Indian centers. The majority of tribal people in the United States live in urban and suburban areas, probably like over 70%. So the 10 urban Indian centers in California are very large have a large population of Native people. And those of you that are from these urban areas are aware of that. So the counties with the largest tribal populations in the state: Los Angeles, San Diego, San Joaquin, San Bernardino, and Riverside counties. And the counties, that's with the largest population in total. The counties with the highest percentage of tribal people, the highest ratio of tribal people: Alpine, Inyo, Del Norte, Humboldt, and Siskiyou. So also fabulous places, but you all know that those are counties that are very remote, very beautiful, but remote. And so that's the counties that have the highest ratio of tribal people in those counties. So that's just a quick overview for you.
Thank you, Holly. So yeah, as she has pointed out, there is incredible diversity amongst our tribal communities. And it's important for us to keep that in mind as we're recognizing the crisis situations there and the historical and systemic roots that come along with that. So for tribal people, what we know is that it may not be a singular event, but something that's interconnected with systemic discrimination that's going to be rooted in colonization, such as forced relocations. We'll also see disruptions in healthy family functioning, the erosion of cultural practices, and limited behavioral health resources as well. So it's important with all of these things in mind to keep in mind the impact of intersectionality. And what do we mean by that when we're talking about intersectionality, and then also being able to be culturally responsive to that? With intersectionality, these are going to be the multiple identities that we carry. So for example, what I shared in my introduction was the introduction of who I was as a Ponca woman. My other identity is that of a Puerto Rican woman. And from my Puerto Rican side, very strong Catholic roots that are identities that intersect, don't necessarily go together too well when we're talking about the religion and the spirituality piece, but those are intersecting identities. And these are things to keep in mind when we're providing crisis response. This also would mean things such as our sexual identity or sexual orientation. It's important for us to recognize that when we're going into those crisis response situations, and what's going to be the presentation that I give with my identity, also recognizing theirs, and does that pose a threat to that individual? So a few things for us to keep in mind when we're working with diverse individuals, even within our tribal communities. So as I mentioned, because the cultural and historical context can directly affect how individuals experience, let me change my slide here, how they experience, manifest, or manage crises. This is important for mobile crisis teams because the responders often entering the historical, social, and cultural environment of the beneficiary. When I think about this, I think about my own sister who died by suicide. And in this situation of crisis response, what my sister was sharing was, in the time of crisis, was that someone had used medicine on her. That's what was happening. That's what was causing all of this. The situation was substance induced, the crisis, but this was how she was interpreting that. These are historical factors that are important for us to keep in mind. So when responding to an acute crisis, look beyond the immediate symptoms, include historical and systemic factors in your needs assessment to tailor your response more effectively and what's going to be more fitting to that individual and how they even interpret the world.
Great, thank you, Dr. Warrior. And going off of that, it's really important to think about those sorts of things. So when we look at crisis, specifically with tribal people, with urban Indian people, we need to look at what's happening right now, of course, but also addressing what has gone on, what has continued to gone on, because that can also inform how we see the situation in front of us. So the types of crisis, we can look at them sort of in three areas: acute, so the acuity of the situation right here and the now, chronic situations, and then systemic situations. So an acute situation could be a disaster, a a car accident, a loss of a family member, a suicide. And this also includes other things like witnessing things that happen immediately in that situation and in that space. These things are usually unexpected and they require immediate support, and versus chronic. And so that a chronic crisis would be something maybe that was acute and it continues to happen. I was a former firefighter and medic, and in that line of work, you experience certain things at such a heightened level, and it sort of hardwires into your nervous system and how you experience these things. So chronic crises can be things like continued exposure to car accident or violence, being survivors of domestic violence, enduring multiple instances of that. Ongoing issues like the impact of substance use can really affect the individual, that community. And so we have to look at that. So you look at systemic, like chronic crises happening can sometimes, and most of the time are, influenced by the system. So systemic crises, something I give an example of is youth suicides and how those can happen in clusters and how those can happen really grouped together. And there's a lot of connectedness to that. And we have to look at what is driving that, what is under that that's causing these things, and looking at the nature of intergenerational trauma, forced assimilation, the loss of identity in land of Native people. That's an example of systemic, of how you change a system and that affects those other three. And I think a better analogy would be all of those things sort of in one bubble, but it'd be hard to get the words on all of them. So all of those things being interconnected, it's important to look at it like that. And so from a clinical standpoint, when we roll up on scene, or we're responding to a call and we're in our mobile crisis kind of mindset, and we're going to say, okay, we're going to assess for the scene, we're going to do our rapid assessment, safety, risk, all these sort of clinical things. And then maybe what we see is just the symptoms and we treat just the symptoms. It's really important to look beyond that, because the acute crisis is often just the tip of the iceberg. It's just kind of, there's so much more driving that. The systemic crisis that person and their family has endured, or the chronic crises that person has experienced. So we might see something that's very uncomfortable in this acute crisis level. And so the awareness of recognizing that and approaching the situation with multiple levels and considerations, and integrating multidisciplinary teams and care if you have it. So that's the rule of thumb. We always respond with partners, and sometimes we have different teams for different things, and being able to serve that person, serve that beneficiary in multiple levels is really, really important.
So what we see on the surface, and what you all see in your work on the surface, when you roll up, to use Josh's term, is only the surface. It's only the immediate. And in order to get to an easier path to de-escalation, knowing other pieces of what that community is like, what the families are like in your county, the Native families, is really important. And as we go through this presentation, we're going to show you some ways that you can gain insight if you don't already have that. But so what's visible is critical for immediacy, but what's invisible, the cultural elements, are really fundamental to not only de-escalation, but the warm handoff, the engaging all the other resources to help that person stay out of crisis. So what you see on the surface is different than, you're not seeing the full picture, I guess is my point. And Dr. Warrior, your example of your Puerto Rican background is an excellent example of what you see on the surface, especially if you have a name like Warrior or my name like Echo Hawk. We make assumptions that is, that's a Native person and that's their world and that's their only world. Dr. Warrior's example of having the Puerto Rican history in her family, which is fabulous, is very different than the Ponca tribe. And the Ponca tribe in Oklahoma is actually very near the Pawnee tribe. So we're kind of know each other. Our tribes have known each other for a long time. But the other deeper levels I'm thinking about is especially the unseen values and their role in crisis response. Different ways that different Native families in your community communicate, how they make decisions, what their decision tree is may be different than your personal life experience. Their comfort with help seeking may be very different. The same thing with the reasons for help declining may not be understood on the surface, but if you really get to know the tribes and tribal people in your county, you'll gain some insight into that. And the help seeking and help declining definitely have an impact on problem solving. So the actionable tip is, before assuming distress is based on visible agitation, if you use open-ended questions to explore underlying cultural norms, that's going to give you more insight on the steps that you'll take in your crisis care. So the next slide is the same graphic, which I actually like this graphic a lot. And we do a lot of work with California Bridge. You all are probably familiar with them. We have a great partnership with them, and this is an adaptation of one of the slides that they use. That's why it says emergency department. But they see, from an emergency room department, they may see what their term is a non-compliant Native patient. What they don't, that's what they see on the surface. But underneath that is a Native person in this example emergency department, which is can be an analogy to your work in the field, is that they may feel unwelcome. They may not feel safe because of the intersectionality that Dr. Warrior was speaking about. Even though you're wonderful and friendly and helpful, if you're not a Native person, they may have had a lot of history of non-Native people appearing to be safe, but they weren't in the long run. Active discrimination, having a lot of past trauma, which corresponds with the ACE scores, and then not really being able to identify with you all as care providers. So all of that's a lot that's underneath a Native person that is in crisis. And they also are often, not always, but you may encounter someone who's very quiet and maybe not actively articulating what's going on. When you ask them the open-ended questions, you may find that many people will be fairly reserved, fairly quiet, long gaps of silence before they speak, if in fact they do. But that's not to be taken as a sign of they're not being intelligent. They're actually Native people are highly intelligent. It's just that the way they communicate, especially when they're in crisis, can be very different. The different standards for calling for security is an example from the California Bridge folks. And you may or may not have seen this in your work, but in the emergency departments, they gave more than one example of an angry white man compared to an angry brown or black person in the emergency department. An angry brown or black person almost always got security called. Police came in, not always the case with an angry white man. So they brought that up as a very sad distinction of the response to, and I guess deep concern of, in this case, an emergency department staff, and quick to call security on brown or black people, not so much on the same behavior from a white person.
So we're going to move into culturally responsive care for Native people. Before we do, I want to just take a minute and ask those of you that are participating, if you could put in the chat. We've talked about a few ways that we've seen intersectionality. I've used my own example with my cultural identities, but there are other ways in which I have intersecting identities as a mother, as a wife, as an athlete. There are different ways that I have these intersecting identities. And I'd really like for us to see what you actually see in your communities or in your workplace regarding intersecting identities. So if you could drop some of those in the chat, we'll call some of those out a little bit later. So let's go ahead and move forward and talk about the responsive care for Native people. So we're going to start off with talking about cultural humility. And, there was this evolution of this term itself, because it started off with cultural competence. And it had good intentions. Let's say that it had very good intentions. And the meaning of that could actually shift to where I'm culturally competent in terms of I have the skills to go and learn about this. What happens there, though, with the cultural competence piece is that level of superiority. I'm going to be looking at it through this lens. But when it comes to humility, the cultural humility, I prefer this term, and I think it fits more with, at least with my tribe as a Ponca woman. One of our teachings is to always be humble. And as we're being humble, it's to not impose a level of superiority to where I can respect someone else's beliefs. I know that everything I do is not perfect. It's not going to be the absolute end all be all. And I have to have that responsibility to continue self-reflection and that critique of my own ways of operating. So that's why I think the shift to cultural humility is a really important term for us. I've already touched on, how that recognizes the power imbalance. Because we're not putting one culture or one belief above the other, but we want to be able to integrate that so that person can be the whole being that they are as a cultural being, and any of the intersecting identities that we've talked about and hopefully that we're seeing in the chat. I'm operating two monitors here, so forgive me when I stumble just a bit. So unlike static skills, humility is a lifelong practice. It's critical to understand the nuance that you're not proficient in someone's culture. You're continually learning to serve them better. It also fosters trust, crucial in mobile crisis settings as a tribal and indigenous individuals often harbor historical mistrust towards healthcare systems. That mistrust, I think, is also important for us to highlight, because within settings, just as what Holly described in terms of how we see a difference in how people are treated, those happenings, those experiences of discrimination are still happening today. A couple of weeks, or I would say last week, as we were reviewing the PowerPoint, I was able to share with Holly something that we had seen that was almost the exact same scenario, just in a different location. So these things are still happening. So that level of mistrust isn't something that's historical. It's been reinforced throughout the years and something that we're still experiencing. That's important for us to keep in mind when we're talking about help seeking and being able to accept help that's being offered.
So just going through a scenario, just to discuss, think about, get that clinical brain thinking and cultural brain thinking. A Native American young person in a rural reservation community is experiencing a severe mental health crisis at their home. It's 2 a.m. and they're presenting with acute anxiety and suicidal ideation. So many Native people have experiences of lifelong marginalization and racism and dynamics between genders and things like that to consider. So when we approach a situation, I'm wondering, what are some initial thoughts that come to your mind, just as you look at a scenario like this? What are some important things for you to consider? And I see some answers in the chat from the previous question that are excellent. Ask other people around for baseline. Great. That's a great point. Knowing that person is a Native person, we exist within the context of our families and our environment and the lands we're on. And so absolutely asking people around them that know them best. What does baseline look like for them? What does normal look like for them? So here are just a few multi-level factors to consider in the ways of thinking. So at the individual level, understanding that there's immediacy with suicide risk, of course. That's life or limb right there. You have to consider that. And at a peer level, in being so socially connected, consider things like you're looking at anxiety, 2 a.m., suicidal thoughts. Was there a breakup? Was there a change in that interpersonal domain that may have caused this? Same with the family level. I really appreciate the theme of collateral information and asking for permission to come in. Those are all excellent. And understanding at a community level also, there may be people, collateral people supports. We as Native people exist in community, and there's clan system and things that sort of govern and have protocols, and there are also Natives who don't maybe align with that. So just keeping that awareness. So in the clinical scenario, like the context of approaching cautiously, I really appreciated that comment about asking permission to enter that space. I'm a big guy, so that was a sort of go-to when I was on the ambulance and fire scene, and asking for permission to enter that space. And the safety measures, assessing, is there access to lethal means? Is the acuity that is going on here, and what's the lethality here? And with permission, asking family members or other social supports, and using that system to say, are there warm places? Are there resources and supports already that this person has established that would be meaningful? Whereas our clinical judgment or our familiarity, we might say, hey, we have really good success with taking, people to this center or this hospital. Then, we need to take a step back and look at where does that person, it's not often that the person gets asked themselves, what is it that you want? Where is it that you feel most connected and comfortable? So the teams that can comprise of a response and that may be supportive, of course, is you on the mobile crisis team. And really the movement of having peers with lived experience, and preferably if you have any tribal or Native people or people who have experiences in those communities, because it's important to have that connection. If you really, I always said working as an EMS chief, and the most important work for emergency medical response at that time was the relationships you have, the training you did prior to when you got the call from dispatch. So for mobile crisis, having those connections, having those relationships built of those communities is really important, so that when the crisis does happen, you already have those relationships that you can rely on. So including EMS, emergency medical for any Dimension 2 type, medical issues that may be complicating, any medical support that may be needed, and social workers, therapists, and for continuity of care. So pass it to Anitra.
All right, thank you, Josh. I'm actually going to go back to the slide. I know that we are limited on time, but there is something that I wanted to highlight. When we talk about tribal representatives, we're looking at those that are going to have that level of cultural knowledge that can support healing. I just cannot stress enough how important that is. And I want to give an example of something that we had experienced within one of our tribal communities. And we had an unfortunate cluster of suicides, death by suicides with adolescents. And it was at an alarming rate, the number that we were seeing, the number of attempts that we were seeing. Sometime after that, as expected, our parents were grieving significantly. It was just a really difficult time. And one of our crisis calls was one of the mothers who was ready to take her life. She had a plan. She knew where she was going to do it, when she was going to do it. And in our conversation with her, we were able to find out what was important to her culturally that would keep her going, where she had a strong belief. And we were able to essentially have an emergency sweat. This included people from the school, from the community resources offices that were available, law enforcement, but this individual said who she was comfortable with leading that sweat, where she wanted this sweat to happen. So even as we're providing that, we have to keep those things in mind, that not every person who has that cultural background, those spiritual practices, is going to be the right fit for this person within this particular tribe. So even within our tribes, we have those differing perspectives. And so it's important that even when we call in that cultural knowledge, it needs to be appropriate to that individual. So I wanted to highlight that, because I think that's so important for us to keep in mind, but also recognize how something like an emergency sweat was life-saving for this woman who had that intent, the plan, the means, all of that was in place for her, and her culture is what saved her. So I think that's important for us to keep in mind in the work that we do. When we're looking at the teachings of our culture, I talked about, with my tribe specifically, the humbleness that we're taught from a young age. That can lead to some of these things, and how we speak. And it's important for us to not draw those immediate conclusions about what's happening. And as Holly had mentioned very early on, that gap of silence, like what processing is happening there, allowing that time and respecting that space is really important for us. And if we're jumping to conclusions, we're essentially taking away their autonomy, removing any type of humility by jumping to those conclusions. We also want to pay attention to speech cadence and speech volume. Sorry about that. There are differences that we can see from different tribes, different communities, and then, of course, the different experiences based on what the actual crisis is itself. We want to provide thoughtful responses. And what we're going to mean by this is that we don't have to immediately jump in and immediately have the solution. We want to be thoughtful. We want to be present. We want to make sure we have an understanding. And what I had talked about before, and what Josh also supported, was finding out what's going to work for them, asking them where's a good place to go. So just being very thoughtful in how we want to respond. Halt impulsiveness to move forward without beneficiary perspective. So that's again going to be, if we're not doing that, we're taking away their autonomy. So this is important for us to keep in mind. And then learning to be comfortable with silence and long pauses. Typically, when I talk about silence and long pauses, I'll be silent during a presentation. See if it makes anyone uncomfortable. Usually does, because it's a presentation. So I'm not going to do that today. But also for us to be comfortable with listening and not over controlling. And this can be challenging because we're there to help. We want to help them find solutions. We want to help them be safe. But we have to kind of check our agenda, even though our agenda is coming from a very good place of health and caring for our relatives. It's important for us to not be over controlling. And then we also want to gain skills to be comfortable with being present. And that's going to go back to not jumping so quickly to find those immediate solutions, but let's be present, because we can gather so much information during that time.
Great, thank you. I just going back to what Dr. Warrior is saying about the sweat. The sweat lodge is a ceremony used by our people for purification and for grounding. And my Dakota side, the Anipi, it's a cleansing. It's a spiritual cleansing. And the sweat lodge itself actually represents the womb of the earth. And when you enter that lodge, it's a very sacred space. And so I just loved hearing that story about that relative, that person was saved by an emergency cultural intervention. I just thinking about all the times, on the ambulance and in mobile crisis, if I would have had a mobile sweat lodge, that That would have been pretty cool. But understanding that, going off of the over controlling part, our history as people with law enforcement, it's important to understand that there's a lot going on. There's the tip of the iceberg type thing. And so when police roll up on scene, they're reacting to that situation at hand. But historically, Native people, we've gone through so much intergenerational trauma with the power dynamic, with the power difference that has really harmed. And so that immediate police law enforcement response is just another reiteration of that. And so it is like a cyclic community PTSD, because that power dynamics there, the unfamiliarity. And so our experiences with that historically have been shaped by that, by the intergenerational piece. So down to a granular level, there's certain jurisdictions, and the Bureau of Indian Affairs has sort of a zoning and outline of how local police officers and federal police officers operate on tribal land. But then also there are things called PL 230 states, which are Public Law 230, and California is one of them, where the state has jurisdiction over certain areas. So it's important to learn about this in your local tribal community, just to get a understanding of that. And so, not that all law enforcement is bad. There is a need for safety and securing things, but the standard mode of law enforcement is not congruent with crisis response. So I think we can all agree on that. And then also from a Native perspective, realizing that there are some things to consider too with jurisdiction and other things. So
we're going to move along and go back a little bit and talk about intersectionality, which is a word I personally do not like. I do not like words that are long, number one, and that are, they come from the fields that we practice in. They're not, you don't hear anybody walking down the street in Alpine County saying intersectionality. But nonetheless, it's an important concept. And basically it's the interconnectedness of different social categories like race and culture and gender are the ones that people often think of first. But I was reading through all the chat, and thank you all for putting things in chat. There's also intersectionality in being a working mom, being someone that's in recovery. So you all have great experiences with intersectionality and how the overlapping worlds and that we represent can be result in different layers and different kinds of intersections of discrimination and disadvantage. It can also mean intersectionality of great things, but in our field, we use the term intersectionality referring to the interdependent systems of discrimination. So this map, can you do it again? Well, this map is an example of where all of the distrust and different levels of systemic and micro and macro aggressions that Native people have and carry to this day is the blue. This map's moving pretty fast, but when you see the map all in blue, that was all Native land, including the gray areas on the East Coast. And this is time lapse to show you the land grab that happened over a period of time. I think this map starts at 1776 to current, but you see there was nothing but Native people here. In Alaska, you hear Native people talk about pre-contact. They use that phrase a lot. Pre-contact with anyone that's not Native. But you can see what happened. Tribes on the East Coast were pushed west. There's active genocide policies, both by some states and US government, to basically eliminate Native people for the value of the land that they have. So the blue turns into white as it gets taken over. The little reds that pop up were the reservations that were developed as tribal land was taken. So I think I just wanted to show you this because just as a reminder, we all know about it, from our education or life experiences, but to see it in a graphic really shows the generations of mistrust that some Native families and many Native families have. However, so we can go to the next slide, please. And I just want to say that in the crisis care world, both clinical skills and cultural insight is needed. And when you combine those two areas, I always think, what an honor to be able to respond to a Native person who has a very unique place in American history and has a lot of knowledge, has a lot of, you may not be able to see it because they're in crisis, but normally very intelligent people, quiet thinkers. But I always think of it as, what an honor to be able to help a Native person. And you do that combining your clinical skills, your humanity, your willingness to share. Roxanne, thank you for sharing about being open about how you're being open about your lived experience really makes a stronger connection. That's absolutely true. You may not be a Native person. You may look very different to a Native person in crisis, but if you share if you take the tips that Josh gave you about, and Dr. Warrior, about how you approach the care you take in, being gentle with that space of the person in crisis, and the tone of your voice, your authenticness. Native people can really tell. We're really good at seeing when somebody's authentic and sharing their heart, or if they're reading off of a checklist of what they are supposed to do. So all of that helps. So intersectionality of crisis and Native history, we're just trying to make the point that Native people in crisis, it's a complex situation. Other people that you work with in crisis are too, I understand that. But Native people have a very unique history, and for all the reasons that we just said. So let me give you, and I think we skipped over a slide, but in essence of time, let's just go to this one. So I want to just give you a quick little example, just the highlights of an example of combining clinical evidence-based approaches with Native practice-based approaches. So this tribe in Washington State developed a crisis response approach for Native people that were living in a substance use world. They were, many of them were living on the streets. This is in the Tacoma, Seattle kind of area. And to make a long story short, they did an investment of developing this tiny home project. And there's 25 tiny homes all in a circle. Each of them, you can see behind those people, there's a yellow sign on the doors or on each tiny home. Each of those have a symbol from their tribe. They have a name in their tribal language. Each tiny home was named, and it all represent a value, honor, trust, etc. And then anyway, when they brought their tribal people home, the cultural department of the tribe had a sort of like what would be considered like a grand opening kind of thing of the tiny home village. It's all in a circle. Where they placed these tiny homes was very Native traditional as well. So they had the Native people there, single people, and some were couples. And they had a ceremony. They sang a beautiful song from their tribe, which was an honor song, honoring these people, their literal relatives and Native relatives. They had a Pendleton blanket that they laid on the ground. And then the Native elder person called up one at a time the people who were going to move into these tiny homes. who were at a very low point in their life, right? Had been through many, many, crises, unheard of crises, um, things that you all see often, some things that maybe you don't see. And but there they were, fresh off the street, so to speak, and standing in front of a tribal elder, standing on this Pendleton blanket. And the tribal elder got very close to them in a very respectful way and was looking directly at them. This is something different. I don't expect you all to do this, but I'm just telling you this story. And then told them, welcome home, welcome back. And they said, we need you back. Our tribe needs you back. You're a member of this tribe. You're never alone. You're home now and you're safe. And we're going to be here for you. And we honor you today. And these people in crisis don't hear that very often. They don't hear someone saying, we're honoring you, and looking at them as a full human, not a person in crisis. And then they, after this wonderful talk that was individualized off the spur of the moment to each person, they actually gave them the blanket they were standing on. So that was their blanket that they used in their tiny home. So that was kind of a good example. There's more to the story, but that's a good example of how, because the healthcare facility was nearby, they had case managers, and they had all of access to all the services they need, from behavioral health to primary healthcare to dental to everything they needed. So it's a good example of clinical approach combined with culture, and how they approach these honored tribal members that they brought back was a really great example. So I just want to share that with you about how important both are needed. Your clinical skills and your cultural insight are both very equally valuable.
And that is a great example of community resilience coming together. And the Dakota term is Mitikaye Wayasan. The Anishinaabe, the Chippewa Ojibwe term, is Indinwe Maganadog, and that means we are all related. And so being seen is such an important thing. And as a crisis responder, as a mobile crisis responder, you can see the person and connect with them. And while you may not be a Native person, you are a human, and you are related in the context of our beliefs and our teachings. And so approaching things that way in a community sense, and recognizing that there are community supports. And California has this excellent understanding in that they appreciate and support Native traditional healing. And also there is the Western kind of classical approach of blending these two things, because meeting people where they're at. I personally don't live in a teepee. I don't cook my food, like the OGs. I have a microwave, and I live on a reservation, but there's a blending of my identity and the intersection of, I do wake up in the morning and I face the east, and I put my tobacco out as the sun rises, and that's a sunrise ceremony. And it's a very sacred, special place. And people look at me and they're like, you're not Native. And so that's part of the invisible identity of some of these medicines work for others, some it's on a continuum. So recognizing that traditional healing and Western medicine, sometimes you just have to ask what works for you, what doesn't. Here are some examples of traditional medicines that are used. And I had full intentions of including in the next slide, the medicines, but I'll get to that. So sage smudging, when you see the bundles of white sage or mountain sage, or California has some brush sage that a really good medicine. We believe in my tribe, when we burn the medicine, it releases the medicine not only to us, but it also brings it up to Creator. And so it's an important practice in our culture. You'll see other things like cedar tea and sweetgrass. Lavenders are used for different ceremonial purposes. So something you might ask is, are there any traditional medicines that you want to include or that work for you? And allowing that person time and space to provide that. chamomile is an example of a traditional medicine that maybe isn't indigenous to certain tribes, but it is a non-traditional sense of non-Western approach, non-mainstream approach to help people with anxiety or stress. And I had full intention of including, because I know I am honored to be sharing this platform with Holly Echohawk. And if you're a Native behavioral health person, you know who Holly Echohawk is, and you know the Echohawk family. And they are huge founders of the Native American Church and the use of peyote and the teachings there. And so I did not mean to omit that, but I'm wondering, maybe Holly, you could speak about that.
Well, it's just another example of every person we encounter. Every encounter is an opportunity, right? And every person that we encounter, a Native person, has a lot of different kind of beliefs. Not everyone uses all of these different practices, including the Native American Church, but it's just another example of resources that you'll get to know if you don't already. And we would like to help you as well in your counties if you need a warm handoff yourself of how to connect with tribal communities. Some of you may need some support, some of you don't, but it's just another example of the different kinds of beliefs and values in soothing environments that families respond to. So Native American Churches is one example of that.
So I've touched on this with the spirituality as a coping mechanism when I shared about the relative who had the emergency sweat, basically. And I also want us to be mindful of time. So I'm going to go very quickly through the remaining slides that I have, which will be shared throughout. But I do want to make sure that we recognize the power of this with spirituality as a coping mechanism. With that, what we can recognize is that incorporating that into our practices. So as I shared, I'm a psychologist, and within our clinics, we have local medicines readily available in our clinic. Those are free to the public, free to anyone who's being seen, but we go out and we harvest this with elders in our community who are teaching us the right way to do it. So we're taking care of those medicines as well and making those available to our relatives. This is a normal practice that sometimes when somebody comes into a session even and they're in a high level distress situation, sometimes what they need is prayer. They don't actually need a session. What they're looking for is, I need to smudge, I need to pray, and let me just be present with that. And we honor that, we respect that. And so realizing how powerful these things can be. There are other practices that we have that I think it's important to talk about, that what is actually happening in those. So we can talk about, we go into sweat, but what's actually happening for us in that? We're actually changing the way our brain is functioning when we're in those sweats. Because if we're focused on trauma, it's like there are neural pathways that continue to get deeper and deeper in our brain to where that continues to be our focus. When we go into something like sweat, or even when we dance even at a powwow, those are changing those neural pathways. That's really important for us to keep in mind, that our culture can impact us in a neurobiological way. That's how powerful it is. So I want to just make sure that we highlight that has a direct impact on our brain, the way our bodies respond, and then of course how we feel.
So being informed about trauma is important, and especially in the context of a crisis, because that in and of itself, mobile crisis response could be a very traumatic thing. Something that I've shared is, you might be rolling up on somebody's worst day of their life. You need to proceed with that understanding. And so being informed about the levels of trauma, specifically with Native people, is important. And that includes what we might see today and on scene as drug and alcohol abuse, obsessive thinking. And rather than trying to pathologize and categorize these sorts of things, it's important to just understand them and to know about them. Because when you are going into community and you are responding to a Native person, these symptoms you see are rooted in things much beyond that. And so rather than just conceptualizing it and saying, I'm going to do this intervention or this checklist, that's where the importance lies, is in connection. It's feeling that connectedness. Because without that, you may be checking boxes and you may be accomplishing your job, but really the goal is to get people to elevate their health and well-being, and you can't do that if you're just if you're not doing this work and understanding these sorts of things. And so another important thing to consider is microaggressions and micro-invalidations. The omission of including tribal people, Native people, and their families and their stakeholders is a form of microaggression, and it's compounding to these sorts of traumas that Native people have experienced. And so without addressing those and considering them, so for me, even though I am a Native person, I am aware of I'm very light complected. I'm a light complected Native, and I'm 6'4.5". And so being aware of my body and how it is communicating in that context of a crisis scene, that's sort of this understanding of being aware of these things. And learning the names of tribes, learning the names of people is important too. So here's an example of something. I want to get this right. How do I pronounce the name of your tribe correctly? Have them teach you and sort of equal that playing field, that power dynamic. Some part of trauma-informed care is recognizing there are other alternatives and physiological devices that might help. For me, sage is one of them. It's a cleansing, purification, and olfactory stimulating, changes the physiology. Other things like portable lights you can use in your mobile crisis response. Breathing aids that kind of have a pulse that vibrates, as you breathe, and then it slows down as you're supposed to exhale. Those can all be very effective sensory aids in crisis response.
Okay, so now we're going to spend a little bit of time because we're using up quite a bit of time here. We're going to go to crisis communication. And with this, we want to think about the language, also the translators, and what is needed in those times. We want to recognize that linguistic diversity within tribal communities and respect the individual's preferred language. I know within several of our communities, we have, and I mean in the North Central Plains, we do have a lot of Native people that speak Spanish and that prefer to speak Spanish. And that's important for us to keep in mind, whether it's a tribal language or having an elder that needs assistance with language, or do we need a translator? It's important for us to also know those resources, who we can call within those communities. And that's going to mean we have to be present, we have to have knowledge of those communities, and we have to know who those resources are when we're serving our relatives in our communities. The other piece when we're talking about language is that nonverbal responsiveness. Excuse me. So we've talked about already silence and sometimes how that can be uncomfortable, but thinking about how do we interpret that silence. The other piece to this is going to be thinking about personal space, touch, eye contact, and how different that is depending on the community that you're serving. When I'm in Oklahoma, it's within our tribe. If we have someone who starts, and I think everyone can see me if you have the full video on, when we go into something that is traumatic that we're talking about, it's very typical to see us do this. That doesn't mean that I'm not listening. That doesn't mean that I don't respect you. What that means is that I'm fully present and I'm totally tuned in to what you're sharing. I'm totally in that space with you. You're going to see that with a lot of our people. Other times with other tribes that I've been at or been a part of in providing work, that eye contact is important. It's very important because they want to know that you're listening. They want to see those active listening skills. Whereas some other tribes may even see it as confrontational. that it's like you're questioning what they're saying. So thinking about those things with eye contact, the personal space, that can be very different for everyone. So that's really something that you always have to keep in mind with, especially how you're approaching people as well. And then you want to be adaptable in your own style. So being able to take cues from the individual's comfort level, I think that's so important for us to keep in mind, because you can see their body language. If I'm getting too close, you can see someone kind of like shrink in their space because they're uncomfortable. Paying attention to that body language is going to be key. Sometimes it may even turn out that you're going to see some aggression if you're starting to come too close into their personal space. So you have to constantly be assessing what's happening and taking that as information to inform how you need to adapt your response. Let's see. And then we have motivational interviewing. What I like about motivational interviewing is, in this approach, it's going to instill more hope in what we're providing and how we're looking at solutions. So it's not anything that's going to be forceful by any means, but it's looking at, if this is where we want to be, how do we get there? What are the things we do to get there? Not what are going to be the barriers that are going to keep us from getting there. No, it's not that. It's looking at how do we get there. And I think that that's a very good way for us to instill hope. It also can build rapport, but it's helpful in letting them see that you also believe in them. Hey, there are ways that we can get there. There are ways that things can change. And this is how it can happen. So those are some key components. There's much, much more to motivational interviewing. And if you're not familiar with that, I highly recommend looking into that, but a very positive approach to establishing rapport and responding in crisis care, but also in any type of clinical service that you're providing. There's a lot of benefits to that.
Great. So this information is really important. However, I also want to respect time. So for the essence of time, everybody here attending will get a copy of the slides, and we have tons of resources and for further learning and information listed, but here's just some brief culturally adapted assessments to consider. So for me, I'm Dakota and I'm Anishinaabe, so the Wichur-Zolny tool is kind of cool, looks at the whole person. And then here, Holly, EchoHawk Holly, did this amazing work about looking at PHQ-9 questions and GAD-7 questions and indigenizing it. And so these are just some examples, and Kaufman and Associates developed these about how do we take mainstream questions that are clinically, maybe sterile, and they're sort of like clinical based. And here's some cultural adaptations of them for use of connecting with a Native person. And so again, really excellent material. I want to stress that, but also everybody will get a copy of these to reference. So just the emphasis on their journey and their connectedness, and kind of moving away from that and looking at more towards like relational, moving away from the clinical lingo and emphasizing on the relational aspect.
Thank you so much, Josh, Holly, and Dr. Warrior. That was amazing in terms of just the wealth of knowledge and experience you all bring. I learned so much just sitting here and trying to absorb and capture it all. And then also just reading through the responses in the chat has been awesome as well. We want to open up to any questions or discussions that any of you might have. There's been a lot of conversation in the chat, which has been great. Is there anyone that would like to come off mute and share if you have any thoughts or wonderings?
I see one question from Jenna. Would it be appropriate to ask an individual about their communication style? Because it varies by tribe and person. I think it's excellent. Transparency is a great policy. And just as Native people, when I introduce myself, I say who I am, who my family is, where I come from, the land I live on. If you share who you are and you're transparent, that allows connection. So I think asking in that authentic, what's your communication style? And maybe understanding that directive questioning too may be not the route to take. You could also say, give an externalized example and say, some people, respond better when they draw, or other forms of communication. I'm wondering if this, might be helpful. And so excellent insight, though. That's great to be aware of, and understanding that it varies by tribe and person and family. So great question.
I do see a wonder in the chat, and I see some responses as well, but this might be great for discussion, and understanding how all of this applies to the mobile crisis setting. And, in terms of mobile crisis services, usually the person that you're responding to, they're in crisis. And so what are the best practices and strategies, and the importance of culture and one's identity, and how that either mitigates or escalates a crisis, is extremely important and crucial. And it's a person-centered approach, right? We're being trauma-informed, acknowledging and understanding how one's experience in the world might have impacted their ability to connect to a first responder or a mental health provider and things like that. And so the more we know and the more insight we have and awareness around the many identities that people have, the many and multiple, right? Like Dr. Warrior has multiple identities. You identify as a Puerto Rican and as a Native person. And so, but like what Josh said, he presents like a white person, right? So a Caucasian. And so understanding that everyone comes with so much, and we should understand as much as possible. And that's crucial in a crisis setting, whether it's mobile crisis response or whether you're working with someone through community mental health services, or in a hospital. It is really crucial with crisis services. I don't know if you want to add anything, Dr. Warrior, Holly, or Josh.
I just wanted to thank Valerie for her summary of that point, which she was exactly on point. And I added that you deepen that insight if you get to know the Native resources in your county and in your non-emergency time. And that's something that we can help with should you need help in your county. I see Adrienne has her hand up.
So the question that and this is something I don't know much about actually, but it occurs to me that while I've been substituting, I've met students that have had trauma and that mature early due to trauma. I'd be interested in having an understanding of what tribal standards of adulting progressions would look like in relation to crisis situations. And I'm not probably phrasing that well, but like a standard of adulthood, the legal standard of adulthood in the US is, age 18. But what has the standard of adulthood in this tribe or this tribe or this tribe been is kind of what I'm actually trying to get at in relation to trauma and crisis. I don't know if it's a question at all even.
I hear the question about adulthood, but I'm trying to understand your connection with trauma.
I've done substitute teaching, and I'm new to working in behavioral health, but the background I come from is teaching, and working with kids and doing a lot of that. The thing that I've wondered is that I've met friends of my own kids that matured fairly early due to the trauma in their lives. And it made me wonder about standards of adulthood as people were raised in different tribes. And how that might reflect into a crisis situation. But just putting it out there as a question. I'm not sure exactly how it could be answered. It didn't come across well, sorry.
No, well, that's great. I was just thinking that Dr. Warrior probably has some more insight than I do, but I'm just thinking about young people who, any young person, right, does not have a fully formed brain and does not have the capacity to, a crisis situation definitely can overwhelm one's capacity of their developmental stage and of their corresponding with their age. And so that's the one thing I think about is how common it is for anyone to become a young person to be overwhelmed because they don't have the life experience, they don't have the skills, they don't have the decision-making experience. They often will make through a suicidal gesture, they're attempting to make a permanent solution to what is often a temporary problem.
Okay, thank you.
Anything else, Dr. Warrior, you want to add on that?
Yeah, so there's a couple of things I'd like to highlight. So when we're talking about the legal age of an adult, that can really be different from tribe to tribe. So as sovereign nations, they create their own laws. So for example, in Nebraska, the legal age to be an adult is 19. And that's for the entire state. You have to be 19 to be considered an adult. However, with the tribes in Nebraska, they're like, nope, it's 18. And so there's that conflict between the state and the tribes in terms of when you're a legal adult. However, when we start talking about a tribal understanding of adulthood, that can be very different as well when we're talking about various tribes and the diversity amongst those tribes. So for example, there are tribes in the Northern Plains that have, and I'm sure other tribes as well, but they have coming of age ceremonies. This is representing that your body is moving into adulthood, but that doesn't signify that you're a full-grown adult, but your body is making that transition. There are other practices as well that would suggest that. Another tribe references the 4 hills of life, and you fit into those areas of this is childhood, this is young adulthood, but it's going to be these larger spans of time that aren't going to necessarily fit into what we see as this is what the research is saying, but this is what has fit their norms within their culture. So there are many different ways that can be interpreted. It's going to be tribe to tribe that you're going to have to develop that understanding. That was helpful.
Thank you, Dr. Warrior.
I just wanted to add one thing, the next slide. If you are responding to a mobile crisis call and it is in the bin that we want to make sure that we make a good faith effort to identify if they're a tribal member and the importance of connecting them with their Indian healthcare provider. And the reason that is because we don't have to reinvent the wheel. So you as the responder do not have to have all those relationships. You just have to know how to connect to the people that do. And the Indian healthcare providers, I think of like the Friendship House, San Francisco, you have these urban Indian centers that already have those connections and networks. And so making contact with them or the local tribe that you serve in your area, your county. And so the reason we do that is because oftentimes those, the Indian healthcare provider, the tribal clinics, have a relationship with that relative their entire life. And so they really already know and have that depth of relationship and knowledge that can really help them in these crisis situations. And they also have the, to navigate the Indian Health Service system. It's very complex. So rather than stress yourselves out, just know how to contact and connect with your local Indian healthcare organization. And then they also can provide insight too, if there's any questions you have. So I just wanted to answer that. And also appreciate Michelle's comment in the chat box, like being disconnected. You mentioned having a friend that was disconnected from her environment. Absolutely, that's so vital, as we are connected to our land and our people. And so I also appreciate that context of mobile crisis response, going to the community, and it's community-based stabilization. So we don't have that after discharge, the continuity drops off because those supports aren't there. So just wanted to highlight, that's excellent comment. So thank you.
There's a question that I want to go back to from the chat. I was searching for it. So Holly, you might have to help me find that one or ask that one for me. But before we do, there was something else that I wanted us to go back to. And this was when Josh introduced microaggressions, micro-invalidation. Something that we have to keep in mind when we're talking about culture is that we don't force that culture on someone. This may not be their way just because they may identify as Native. That doesn't mean that they're going to want to smudge. So if you show up trying to force that on them, that's going to be a microaggression. Even if it's a Native to a Native, that's still a microaggression. If that's not their belief, but you should be doing this. You need to smudge. You need ceremony right now. That's a microaggression right there. So we cannot force those cultural components onto any of those that we're serving.
So here's the question from Scott. A really great question, Scott. How do you determine the difference between cultural silence? Because we talked about some Native people, and many actually will be pretty quiet, have long pauses. How do you determine the difference between cultural silence and being in a state of too psychotic to respond?
Mm-hmm. That is a great question. Thank you for that. And that one, it can be challenging at times. It's important for us to think about the behaviors that we're seeing, because when we're talking about psychosis, there can be varying levels of psychosis to where there may even be active hallucinations. There may be that dissociation. Oftentimes when those are happening, you're going to see behaviors that are going to be suggestive of that. There's an activity that you can practice. It takes 3 people, and 2 of them are, one is going to be, let's say, someone who's listening to someone talk. The other one is doing the talking, but the third person is going to be that hallucination whispering in their ear. It's important for this person to see what the behaviors are like, because you can tell if someone's having a hallucination. They might be looking away. They might be like moving their hands like this, or there may be a time where it literally looks like their eyes are glazed over, like they're not present. That can be an indication that, okay, this might be more of a form of psychosis versus that level of respectful silence. With respectful silence, again, it might be where I had shared, like their head might be down. There may not be eye contact, as we've talked about. So it's something where you have to really assess the behaviors that you're seeing and see what looks abnormal in terms of what would be suggestive of psychosis by the behaviors that they're showing you.
I just had a question about finances regarding mental health care in Native American tribes. I know just in general, sometimes it's hard to find in non-Native American cultural areas where it's so expensive you can't really get the help that you need. I know there are a couple of Native American centers here in Yolo County, but I was wondering how common is it for them to actually reach out for mental health care, and are they subject to the same sort of financial issues with that?
Mm-hmm. What county are you from, Valerie?
Yolo.
Did you say? I'm
Yolo
sorry.
County.
Oh, Yolo.
Mm-hmm.
Many tribal people are Medi-Cal eligible, so that's one piece of the finance. But that's an important question though about the finance, because it's a little complicated. But the local tribal organizations and health programs that serve Yolo County are very well schooled in all of that, and that's part of what I'm talking about, mentioned before, about relationship building with Native programs in your non-crisis time. So you have those resources and they can help answer those particular questions.
All right, thank you.
I love that question, Valerie, and I think that suggests another webinar just on funding for behavioral health services, because it is so terribly complex. So thank you, Holly, for the way in which you summarized that for her and giving her the resources, because if I would have answered, I would have started going into the shortage of providers and everything else. So thank you.
And I see that Ruby, do I have the name right? It disappeared from my skin, was asking a question of how do I start getting connected, I think, to tribes in your community. And I don't know what county you're from, but there is a technical assistance component to this work in mobile crisis response readiness, and we're available as part of the team to help with those connections. We did that with California Ridge and help California Ridge connect with tribal people in their different counties. So that is, I hope that you submit that question, or I don't know if there's a place on the survey so we can follow with that, Ruby. Is it Ruby or Rudy? Your thing disappeared, so I couldn't quite catch who.
It's
there it is, Ruby.
Yeah, Ruby. I think that, you know, Ruby, you could submit a TA request if you want to learn more about how to connect with the tribal communities where you're at. And we can absolutely connect you to Josh and Holly and support you with that. And TA requests can be made on the MTech website. And I really want to thank Josh, Holly, and Dr. Warrior for being here today, and all of you for taking time out of your very busy schedules to be here. And I wish you all the best of the rest of your day.